With Dr. Janine Winters, Otago University, Bioethicist. Good morning.
Good morning.
This is a crazy day for lots of reasons. Where I live in Dunedin, in a little area called Northeast Valley, I was about to take the kids to school this morning at 8:30. All the power goes off. I was like, oh shit. Not to be flippant, but my power has just euthanized itself. It has disappeared on me. What am I going to do? Considering I've had a podcast for a client an hour ago and then we were going to talk today. But luckily, the lovely people putting in power poles have put us on a generator power. So our power is here. We are good to go. Hopefully it will stay on. If we disappear, we apologise, but that'll be the reason why. And then, of course, we've had technical breakages and issues in the studio today. But we're here. It's almost like someone's trying to stop us having this conversation because you've been a bit ill in the last couple of weeks as well. So,
yeah. Yep.
Oh gosh, we're all going. Look, we talked 2 years ago, and you were saying almost to the day.
Almost.
Because I remember my mum passed away on the 11th of October 2 years ago. So we've just had the 2-year anniversary. And I was talking to you. I mean, as you would appreciate, it was all a bit of a blur for me, that time of my life. But it was within a week or so of her passing, we were talking. And we were talking about euthanasia.
That's right.
And we were talking about euthanasia because you had written a piece that was in the ODT that was talking about why you didn't think that legislation in its form at the time was a good thing. You weren't supportive of it. I guess I can paraphrase to say if the referendum had have been then, you would have voted no.
Yep.
And I just thought this is probably a good time for us to reconnect. Now, full disclosure, I was going to have kind of a debate. I had a couple of people lined up and an academic that was going to vote no and an academic that was going to vote yes, and we were going to have a big conversation about that. But through several circumstances, some of which being my slackness, that all kind of fell apart. But then you and I spoke the other day, and I thought it's a really good idea to revisit with you because we do have a history of talking about this, and the legislation has changed.
Quite a bit.
So I thought maybe what we could do to start with, and this will be a quick podcast for how we normally roll here, but because this is not really our flowy, generic-y one, it's more of a let's talk about the referendum. Could you just remind us all, 2 years ago, like in a nutshell, in 30 seconds, 60 seconds, what your concerns were then about the proposed legislation?
It's hard to do it in a nutshell. Some of them include that the using autonomy only as the basis for decision making for somebody who's in a position of high vulnerability.
So by autonomy you mean the person making the decision themselves, so the person who is sick.
The main argument for euthanasia is it's my body, it's my life, it's my death, and I should have the control over that process. But the concerns is that people, when they're adjusting to the idea of a disability or their own mortality, that they're not in their best position in their lives to be making decisions that are uninfluenced by emotion and despair and being, I just call that group as a vulnerable, that we are all in a vulnerable state when we are very ill, and that's not our best decision-making time. And that to have some boundaries around that decision and to involve other people in that decision, including doctors, but also we talked just a minute ago about independent witnesses. You had a great slide up on the wall that I don't know if you could bring up again.
Yeah, let's bring this up. Let's first bring it up for us in the studio, and then let's bring it up for the people at home. I'm actually not 100% sure where this has come from. It was an advert in a newspaper that I came across, I think on Twitter or something. I can't make out who the people who have put it out is, so I guess I've got to be careful and say this is not mine or ours, or I don't endorse this wholeheartedly, but this is a representation of why a particular group doesn't like the End of Life Choice Act as it is right now.
Yeah.
So it says, for those who are listening, it's a graph of 4 countries, of which New Zealand is listed, and territories: New Zealand, Victoria, Canada, and Oregon. And it has listings of independent witnesses, a cool-down period, a specialist medical advice, assessment of competence at the time of lethal dose, coercion into euthanasia as an offence, I guess that means for the country, and mandatory training for the doctors. And this particular advertisement, which I guess is based on the legislation, says New Zealand doesn't tick any of those boxes, whereas someone like Victoria, which I'm assuming is Victoria, Australia,
Yes.
ticks all of those boxes. So in other words, if you coerce someone into euthanasia, it's a criminal offence. There has to be specialist medical advice. There has to be a cool-down period in Victoria. And Canada and Oregon have a mix of, they do tick some of those boxes, they don't tick other ones. So that's the... and if people are listening to this podcast, jump onto Facebook or YouTube or Twitter and you'll be able to see this foot. What are we? We're about, go straight into it. We're about 6 minutes in.
Okay.
So people go 6 minutes in, they'll see this thing up on the feed as well.
When I came in, this was the first time I'd actually seen this advertisement.
All right.
And it addresses a couple of the things that were my concerns. So one is that I just said autonomy, or the conditions of the person who's making the decision. Another concern that I have is about the people who are administering the lethal dose of medication, which is
so
the
when
doctor
you
or nurse.
you said have, so these are still current, or are we still talking about what it was, or have we kind of started to meld between the two?
Yeah, we're melding between the two. So
Fair
maybe I think that.
Well, could we ask this question instead?
Yeah.
What's changed in the legislation?
That's a great way
that's
to
an easier way
go.
of doing it. Since we talked 2 years ago, people can find that, and now what has changed, and let's go on to what you think about the changes.
So I think that the changes have been really important, and that the changes have made a big difference in the legislation. And the biggest change was to be crystal clear that a person cannot choose euthanasia for only because of a disability, because they are very aged, or for that a mental health issue, that they must have a terminal diagnosis that is thought to result in their natural death within 6 months.
So I've read off that part of the bill that says basically you got to die within 6 months. That's new in the last couple of years.
Yeah, well, but you don't have to. Yeah, I'm laughing because you got to die within 6 months. You know, in palliative medicine, we notoriously know that we are not great prognosticators in deciding, how long people have to live. So that is a concern that continues to exist. But I appreciate that the legislation has confined the group of eligible people to people who are thought to have a terminal illness, because where the ethics get really difficult are for people who don't have terminal illness. How do you decide about suffering, which was the criteria? Without the terminal criteria, it was only suffering in a way that was irremediable by a method acceptable to the patient, and that you have a decline. Well, everybody has suffering at times, and everybody has a decline. I thought that was just a description of the human condition.
Right.
But
now there is attached to it. There has to be a diagnosis of this person has 6 months. Whether it became 8 months or 12 months, we don't know. But there needs to be a diagnosis of imminent death.
That is thought to be imminent death.
Okay.
Yeah. Now
that's a pretty big change.
It's a very big change, and I think that it's a good change for this legislation, especially since it's new. I mean, you can someday challenge. I know there are people who would want to challenge that later, particularly for the neurological diagnoses where they have a decline from a neurologic diagnosis that has an unknown what the trajectory is going to be. But as a place to start, those cases where people have a new onset of a disability, say that they are newly have tetraplegia, of spinal cord injury, a high spinal cord injury, or they have a new diagnosis of motor neuron disease. One of the things that we know is called the disability paradox, which is that as people become more used to their disability, their rating of their own quality of life goes up, and that there is an adjustment period to having a disability where people are depressed and they don't feel very good about their prospects. And then with time, that they actually rate their quality of life up towards the average.
Okay.
And that to everybody's surprise, how we imagine being disabled is actually different than the experience of being disabled.
So there's a shock period at the start where people will go, holy crap,
Yep.
my life is the worst it's ever going to be. It's not worth living. But
Yes.
as they learn day-to-day life living with this disability,
Most people.
improve in their psyche and in the reality of their life.
Yes.
Right. Well, that's cool. That's interesting.
Yeah.
So, is there any other significant changes other than the 6 months still, and the without the mental health issues? Are there any other big changes?
Yeah. Well, there were quite a number of changes. One was a clarification that the healthcare provider is not the person to suggest to the patient that euthanasia is an option, and there have been arguments on both sides of that, but I'm quite grateful for that at least there's clarity. Since I've talked with you, I spent 2 months in Canada interviewing 22 providers of medical assistance in dying, which is the name for the legalization of assisted dying in Canada, and talked with them about their experiences with it and what it's like to be a provider. And one of the things that was hard for many of them was a balancing between, I don't want to put it into somebody's head if it's not already in there. On the other hand, we know that people who are highly educated and very forward-thinking know about this option for assisted dying, and that people who are less sophisticated in their healthcare knowledge and who are economically disadvantaged don't even know that this is an option. So should I tell them? Is this part of informed consent to tell them that this is an option? But then how do you do that without inadvertently telling people that their life circumstance is so poor that they're better off dead? So there was a lot of struggle, and the doctors that I talked with, some of them really agonized about whether, when giving somebody a diagnosis that meant that they were going to be going through very difficult times, either with a very bad disability or a terminal diagnosis, whether they should suggest to them that this was an option. So our bill here in our act actually here in New Zealand is specific about that the providers shouldn't bring it up.
So at all.
It has to be patient generated, brought to the healthcare provider.
Are there any criteria around there? I'm not trying to split hairs or think about ways around this, but lots of doctors' surgeries have lots of walls of pamphlets with information about it. Can it sort of be out there as here are your pregnancy options, here is a thing on assisted suicide, or are they not allowed to be? Basically, would that be considered, informing the patient, like you putting the idea in or not?
I think that would be neutral, and I think that is a part of the implementation. And I'm very at this point. I come down against the bill because of the flaws that are still in it, but I think that the devil is in the details. I may have said that on our last meeting, and I'm quite interested in the implementation of it and how to apply some of the things that I learned from talking with the providers in Canada and with our situation here in New Zealand about answering questions like that of what does qualify as informing the patients of their options. I would think that a pamphlet would be neutral because it would be available to everybody versus selecting out somebody with a new disability and saying, well, that assisted dying is an option, and that could be very easily a signal to the person that their life isn't worth living.
Yeah, sure. I was thinking as well as you were talking, before we go into why you are still not supporting it even with these changes. I guess what I'm about to ask is kind of silly because there's always going to be dodgy, rogue people out there. But, is there a chance that even with this legislation and with the new criteria that doctors may err on the side of person's got 12 to 18 months to live, but they say you've got 6 months to live to give you that option of, being in there? Has that conversation come up at all? Is it a consideration, or is that covered sort of under the ethics of how doctors should operate anyway?
Well, I haven't heard anybody talking
It's
about that
my
at
dodgy
all.
brain then.
I will say that one of the things that I found from interviewing providers in Canada is that each one of them had given this a lot of thought about which patients that they felt comfortable in providing assisted dying for, but that each one was very different. I interviewed people who had provided assisted dying to over 100 people, and it's only been legal for 3 years.
Right.
And I talked to people who had provided for a much smaller number, but who had concerns about what other doctors were doing. And they're like, well, I operate within the law very strictly, and took strict interpretations like that we just talked about as a brochure informing people of options. Well, there's other language that can be very strict interpretation. You can take very strict interpretations, and they would take that. And I'm comfortable as long as I use this interpretation of the language in the bill, but in the law. But I don't like what other doctors are doing.
You say and use the word interpretation, and I think that's a way that whatever aspect and area of life we're in, we use that kind of phrasing to get around things. I interpret it a different way. It would seem with this kind of legislation, maybe it's not possible, but you'd want there to be no, in my opinion, there to be no room for interpretation. You'd want it to be, it has to happen this way, even if it means there's a formula on how you have to communicate with patients about it, because as soon as you go to that phrase of interpretation, that's how this person interprets the law, then things can be happening outside what technically the law was set up for.
Absolutely. There's always unintended consequences when, law is actually a fairly blunt instrument. And one of the things I'm interested in being involved with implementation would be the training of the providers. Let's go to now to the stage of even though there are some significant changes which you've acknowledged, you still have not come out in support of it. So you still haven't voted yes for some reasons. Why don't we go to that, and then you can talk about, because I know we talked on the phone briefly. You said about if it does get passed, how you'd like to be involved. Why? Let's stop before we get there. Let's just stick with. Why are you still coming down on the side of no? So there's the patient factors that we started to get into about vulnerability. There are family factors. This can be a secret from family members, but secrets have a bad habit of coming out. And so I think that families could be quite traumatized to find out that their loved one, who they think was in a vulnerable position because of a recent diagnosis or disability, and that they come back and that they proceed with information that perhaps the doctor who interviewed the patient didn't know about, that wasn't disclosed by the patient to the doctor.
So when you say this could be a secret, I know that maybe when I go, let's have an example, that may not work, but when I hear the word secret, I think something that the family doesn't know or that people don't know. Could someone be in hospital under this bill? Could they make an independent decision autonomously themselves, say, I want assisted suicide? They could do that all without an interaction from their family.
That's correct.
So what I'd like to know is then once the family found out that person had died, does the doctors then have to inform them they chose this? Or basically they just say they died in the night? Do they have to then, even after death, do they still not have to pass on how this person died?
That's correct.
So what happens when
they do not have to pass on anything, and in fact it doesn't show up. It's specifically prohibited by the law for showing up in disclosable, findable medical records. So it's not part of their medical records.
So what happens when the family turns up, and I've had this experience in the last few years, and goes, what happened at the end? Why did this? My mother, my father, my husband, my wife, yes, they were ill, but it seems that it wasn't. What happened overnight? How did it all end? What does the doctor say to that then?
Well, they're going to have to probably rely on what they'll put on the death certificate is this underlying diagnosis of whatever the terminal condition was, and then they'll probably be in a position where they'll have to confabulate a bit because they're not supposed to. It's a confidential from the family.
That's a nice way of saying lie.
Yeah.
Yeah.
You could probably do it without lying. Your mother had and you name the illness that they had. But yeah, it's a live omission for sure.
But what you're going to do is you're going to get people like dickheads like me who are going to look at a doctor and say, what was the cause of her last breath, his last breath, whatever it was? And it's not going to be because of the cancer they had. It's going to be because of that. For them not to answer that would have to be a direct lie. Because if this was to come into law, and if that was to be the case, people are going to, you know what? People aren't going to trust the medical institution as much.
That's exactly. So that is the other major concern that I have is the trust. So as a palliative care doctor, there is no way that I can support this. I can't support doctors doing it. I can't support it being done in any kind of a facility where we offer palliation, comfort care, because people are already worried that we are euthanizing people, especially people who are in a group that might be considered disadvantaged, or that their life might not be considered as valuable as somebody else's life. So members of ethnic minority groups, who have disabilities, anything impoverished perhaps, anything where they would have a concern that somebody else would say your life isn't of value, that those groups already under access care for comfort at the end of life because they're afraid that we're going to shorten their life because we don't value them.
When we last chatted 2 years ago, I was obviously in a bit of a blur. It was within a week to 10 days of my mother passing. I didn't really have my thoughts together. I remember talking about some of the things that, because what I thought would happen is my mum had motor neuron disease, right? So she passed away and knew it was coming. It was sort of a 3-year period, pretty much like all the motor neuron disease, cases. It was fairly typical. But there were some moments towards the end of her life that are some of the most memorable moments for me, up to and including, I was the only person in the room after Mum passed. I had this sense in me that I couldn't leave the body. And I've joked in the past it was my Māori side coming out, even though I have no Māori in me whatsoever, as you can see by this stupid ginger beard. But there were some things that were really important to me that I really cherish today. And I didn't vocalize this to you 2 years ago because it takes time to think this through. But what I realized of recent times from my perspective is much like the saying that most people would agree with, that it takes a village to raise a child. Raising children is a community activity. I think death is a community activity as well. And I voted for the euthanasia bill and I voted no. And one of the reasons I voted no was I think that under its current form, it takes away that idea of death being a community activity, exercise, and I think perhaps non-Caucasian, non-Western cultures probably do it better than a lot of, Commonwealth type countries, because it does become a full village, activity when someone passes. So I voted yesterday actually, as of recording this podcast, and I voted no, and that was one of the main reasons. One of the main reasons was thinking about the experience I had with death, which wasn't mine. So perhaps this is a selfish thing, right? Whereas when I voted for the cannabis thing, I voted about other people's experiences. For this one, I voted about my experiences, and I went, it's a community activity. One of my concerns, I'm not saying I'm anti this euthanasia in general, but how does this get implemented? And maybe that Victoria, if I can bring that, maybe that Victoria example has it. I don't know of it, but how would this be able to be carried out as a community, family, whānau experience rather than not? So that's why to come back to your autonomy thing issues and secrecy. That's sort of one of the reasons I came down on the no. Right.
So the people that are involved, other than the person who is wanting assisted dying, are their family, their community, and the person who has to kill them. So those are all parties that have an interest, and so the secrecy in the family, I think, could be very, very damaging when you find secrets have a way of coming out as well, and that it could be very damaging to family members to have to live with the fact that their loved one was killed, and perhaps that since the whole thing is confidential, that they can't even look into the facts. There is no independent witness that signed it.
Explain that to me. What's the independent witness's job?
In Oregon, you have two people that the patient gets to choose who they are. So if they can still bypass if there is a family member who would try to obstruct their exercise of their own will. But they have to choose two people who would come to them to their appointments with the doctor to say that they had informed consent, that they actually were told all of the things that they were supposed to. And that
the patient was telling the truth?
And that the patient wanted this, and that was their free
But also
decision.
The patient was giving full and fair information.
That the patient was given full and fair information. And I think that is important because when family members I think that inevitably there will be disgruntled family members. Everywhere where it's legal, there are some disgruntled family members, understandably. And when it's death and the emotions are so high around that, then it becomes charges, even, murder. You can't come back, from a mistake.
Yeah.
And then it doesn't protect the doctors either. And I'm hoping in implementation that there would be ways of protecting so it's not the doctor's word against nobody, really, because the patient's dead.
That's true. Actually, that's really true. Actually, if I was a doctor, I worked in and around primary schools for a while. I don't like using the word teacher because I was so bad for the education sector. The best thing that happened to the New Zealand schooling was me getting out of it. But there were electricians and builders and people who refused to come on site until all the kids had gone because they didn't want to put themselves in a position where, and I'm not saying this doesn't happen, but a kid would make an accusation against one of these guys, so they'd all turn up at 4 o'clock to do their jobs, if there was an electrical job. What about the flip side to this? What about the doctor who then gets accused of doing something they haven't done? Where are their protections in this? And vice versa. What if, again, you had what do they call them? I can't think of the word, but I used to watch one of those CSI programs when they talk about a nurse who would put someone out of their misery as an act of mercy. Mm-hmm. Where are I'm assuming there must be paperwork, so there's probably protections in place for that. But as soon as you say the word secrets, I kind of go, holy shit, there could be all sorts of things that both potentially harm the patient from a rogue doctor or harm the doctor from accusations from other people.
Right. And this is where the loss of trust is key, because there isn't good protections for the doctor, and when the family is feeling like their loved one was killed, was murdered, and especially if there's a community behind that, say that they belong to a member of a cohesive community, perhaps a vulnerable community of some sort, and then there's all the anger from the entire community.
So there may be an advocacy group that gets onto it, or whatever it is.
Or if it's in the same iwi, if it's a disability group, if it's any group, refugee group, any group that has difficulty with being discriminated against and is worried about that. And now we have a person who's dead and can't tell them the circumstances.
No coming back from that one.
Right, no coming back from that one. And how do you know if you can trust that doctor? There was no second person who had to be signing off on the conversations. Now, there is a second person in this legislation that has to sign off that the person had the capacity to make the decision. There is a second step with a doctor who makes sure, a second doctor independently makes sure that the person has capacity and that they are that they can make this decision, that they aren't blunted in some way with their brain not working, have capacity or competency are the other names for that. But they don't have to go through the whole process with them and try to decide if this is their authentic wish, or if they're just feeling desperate right now, or if they're having depression right now, or if they're this is in line with their lifetime values, or if this is something that is new because something really bad has just come up in their life. And those things, I think, are important.
Okay. Anything else from the bill that's caused you to go down the no path?
Well, I very much dislike that the injection, it actually can be oral or injection, but I think it's going to be given by injection most of the time because the person providing it, the provider, has to be at bedside between the time of the administration of the lethal agent and the death. So if it's given by the oral route, then that can take a long time. If there's vomiting or some other thing that happens, that it would have to be re-administered, and but it could be an all-day affair for the provider, which means that it's going to push it towards the IV route because then that happens very quickly. So then you're talking about going from something that's perhaps self-administered by the patient by the oral route to something that's, the full-on euthanasia, doctor standing there injecting a lethal substance into a patient's veins that kills them within minutes. And I think that pushing it in that direction takes the agency more out of the patient. The patient's doing this to themselves. They're being assisted in suicide, to the full-on euthanasia, which is the doctor is taking that moral burden of killing them.
The one of the examples over the last kind of 20 years is the Dr. Kevorkians of this world, and they seem, I don't know exactly what it is, but I've seen a couple of documentaries, and they seem to have something that they'll turn up, they'll put the things in your veins, but then you have to, you have to administer by pushing a whatever it is, plunger or button, or start the process yourself. Could that be an in-between stage?
Well, yes, and that's again in the implementation where we have some room. I believe it's the Victorian legislation has a way for people to get it IV and to have somebody administer to it if they cannot. But the default is that it's more towards the self-administration when it can be. And I think that would have been wise to have in the legislation.
I can't imagine a doctor who's done 7 years of medical training and X amount of years in practice, whatever, coming home, I'm being naive here because I'm not a doctor, but coming home from work to see his partner and his kids. What did you do at work today, honey? I killed 3 people. I can't see how doctors in general would want to do that as a part of their, do no harm practice.
And that's very much is a concern.
But I don't know how doctors think about that, obviously.
Again, there's some doctors who absolutely rule it out, and I really don't want to be involved with providing. I will not be a provider. Absolutely not. This is where
would you be
where
able
my
to say
own
no?
personal I'll be able to say no. But my own personal thing, why I'm divided and more moderate, I think, than most is that I could see myself wanting to be a consumer. I
was going to ask you that,
but not as a provider.
No, I was going to ask you that. I was going to ask you at your end of life, would you want the option for some kind of assisted suicide?
I doubt that I would want that. The way that my worry about death is my grandmother's death, which was of a long-term dementia, and there's different kinds of responses to dementia. Some people are happy, demented people who have a good quality of life and are very, cheerful and go on a path sometimes that has a lot of meaning. And others are very unhappy people. My grandmother screamed every time she was bathed, every time she was toileted. She couldn't, she didn't know who we were for 7 years. And I don't really want that death. On the other hand, as an ethicist, I also understand that that's the hardest one to legislate or to make it, to make an advanced directive, which is what it would need, because I wouldn't have the capacity to say, well, now is the time when my quality of life is bad enough, that I'm unhappy enough, and I have this dementia, and I can't, do my own activities of daily living and feed myself and all that. Okay, now it's time. Somebody else has to make that decision for you. And that is really morally difficult, because how do we know when that person has had enough. And what we do know is that the advance directives that they leave, because of that disability paradox, they might say, when I no longer recognize my children, then I want to be dead. But there are people, examples that we know of where they can't recognize their children, but they enjoy eating, they enjoy music, they sing, they have acquaintances and friendships in their rest home, and they smile a lot.
Yeah.
And do you want to be the one holding them down and shooting the stuff into their vein? There was a case in Europe where the family and the doctor held a woman down who had end-stage dementia, who had left advance directives, and her family and her doctor said, okay, this is, we think that this is what she would have chosen. And she said no, and they had to hold her down. And it came to, it's gone to the courts, and the doctor and that allowed this to happen was censured. I think if that happened in another country, it could easily be a murder case.
Well, that sounds like murder.
That sounds like murder, exactly. And so that's the problem. So for me personally, I think that the death that I'm afraid of, which is the long-standing dementia death, is the death that I don't see how it can be legislated ethically for who decides and under what criteria and how of when somebody has had enough of dementia.
Wow. I think, would it be fair to say that these conversations happen a lot with you at the moment? You've written another piece for the ODT.
Yeah.
Do you get a sense out there as to what the vote's going to be? Like, do you talk to most people? Do you find most people are... Because up until like this week, I haven't got a clue where I'm going to vote. Honestly, they're one of the reasons I wanted to originally have sort of both sides have a debate. And the reason I'm speaking to you only so people know is that I think it feels like you can look at both sides of this. Which is why I thought just you and me might just have a chinwag about it. But I really didn't know what I was going to vote up until recently. Whereas the other referendum, I was very clear from day one. It was a very easy decision for me personally. Do you get a sense of the people you talk to? Is this going to be a close one? Is it going to pass? Is it not going to pass? It doesn't matter the answer to this question, but what do you think?
Yeah, I think it's more likely to pass than not, but I'm...
Really?
Yeah, well,
Wow.
the surveys that were done in New Zealand in the years leading up to this, and this is, the third bill, the first one that's passed into act, but the third one in New Zealand. Certainly in other countries, this has been a movement as well. However, I will say that I've seen more advertisements against in recent months than I ever have, and they're good. They're bringing up the points that I have, my concerns. So, like the thing that we looked at a little bit earlier, has makes some excellent points. So hopefully the public is more aware of what they're voting for, and that the devil is in the details, and that you can, have a general sense of assisted dying. Maybe there's a place for assisted dying, and still be against the specifics because of the details being so very important.
Someone said to me when I was talking about having these conversations, and I said, I'm going to have people on who aren't necessarily against the concept of euthanasia, because I'm pretty sure you said that last time, and you referenced Oregon the last time we talked, but they're just not into this one. And one of their responses was, yeah, but they always say that. Basically, they weren't accusing anyone in particular, but they were saying a lot of people who say, I'm not against it, but just not this time. Basically as an excuse that they're always going to be against it. So you voted or going to vote, I don't know if you voted or not, no. What would you need to see for you to vote yes? Is there anything, or are you one of those people, and I mean this respectfully, that is always going to vote no?
Well, I'm never going to be I never want to be a provider, but then I have that double sense of, if I'm never going to be a provider, but I might consider as a consumer, that's not a very tenable situation. I think if the Oregon bill had come, I might have voted yes.
Okay.
But I still wouldn't be a provider.
All right. And I guess last question. You and I have talked briefly on the phone, and I'd like to expand on it just for a little bit here. If this does go through, you would like to have potentially a role in the detail, where the devil actually sits. So let's say that this passes, and I think all parties have agreed that this will then become legislation. What would you like to then see to make this detail, the devil that's in there, as safe, as workable, as fair, as equitable as possible? And how would you like to help in that situation?
I think the first thing would be to have both training and supports for the providers, so that that interpretation that you talked about a little bit earlier is more of a group interpretation, and less of an individual rogue, less opportunity for individual rogue interpretations that span the whole spectrum of opinion, so that there's sort of a practice standard. Like I said, I think the law is a blunt instrument, but that professional organizations and people who are close to the providers or people guiding the providers can make some more subtle distinctions. I think that there's going to need to be support for both the families and the providers, so that the families in the grief and bereavement process, that they have opportunity to work through that. The person, in the end, the person who is dead, right?
Yeah.
And it's the rest of us who have to live with how that happened.
Yeah.
And have to come to a resolution on that. So I think that needs, in some instances, that's going to have to be supported, because if it doesn't, they're going to go to the press, and that they're going to bring out their discontent and their sadness and their suffering is going to come out in ways that will generalize it to other people, who will then become concerned on their behalf, and a lot of anger. And I think that could be very bad. And then some of the specifics, things, like the administration, what can it be done more with the patient taking more agency and the providers taking less? Medical students and residents and registrars are training. How are they going to be able to choose or not choose to participate in that? We have conscientious objection clause in the legislation, but it's very difficult for people on the bottom of the totem pole, nursing students, nurses, even the people who bathe the people. Are they allowed to say, I have a conscientious objection to euthanasia. This person will be having an assisted death today. I don't want to be the last one to bathe them. I mean,
right. Wow.
That was actually something that came up in when I talked with providers in Canada, that there were some people quite traumatized by things that nobody had thought about, like the person who is about to have assisted dying crying and saying, you're giving me my last bath in my lifetime. And that person who was providing that bath hadn't been told about it in advance, hadn't been mentally and emotionally prepared for that experience, and then had a lot of grief and I don't know what else, maybe anger afterwards, that they were put into that situation. So there's going to need to be a lot of thought, of unexpected things, that the imagination's going to have to be pretty broad into what can go wrong and what can go right, and trying to make those things align so that we can get those details right and learn from these other jurisdictions that have legalized it, and not make the same mistakes that they've made.
It reminds me of that saying, if I've seen further, it's only because I'm standing on the shoulders of giants, looking at those who have done it before us and making it better than what they've done.
Yeah.
Hey, Janine, thanks for coming in.
Yeah, thanks for having me.
I appreciate that, even though you were maybe not 100% healthy wise, that you're still stuck in there. I think this has been useful. I think there's some things have actually come out in this that are, for me at least, even more so of an understanding. And I know that probably, I read the other day that 1.1 million people have already voted, probably 1.5 to 2 million already have now. There might only be another million or so to go, because 50%, so to speak. But at least for some people, this might give them something to think about. And thanks for coming in. And I guess we'll book our next chat in for 2 years from now. Is that what we're doing?
Yeah, we can talk about how it went.
How it went. Janine, thanks for coming in.
Thanks. Bye-bye.